Thank you very much.
Thank you.
It just seems like yesterday we were at your house in Jersey for a summer fundraiser. I hope we don't wear out our welcome. If we don't, then we'll do this again next week. Okay, just want to make sure. Okay. We really have an informative night planned for everybody tonight. You obviously hear from Michael in a few moments. He'll give you some words. We're also going to hear from Rabbi Goldwasser, our referral guru, and Dr. Scherr to give you some updates in terms of cancer and some mental health issues. Before I roll it, I just want to say something. As president of SBH, I am often asked what it is that SBH does. I think tonight is the perfect answer. While yes, we provide community members with food, rent, utilities, counseling at our counseling center, fertility advice and support, as well as job placements, and so many other vital services. But in reality, our mission is to meet the community where it is and answer those needs with a full, comprehensive solution to completely look at the client and what they need. So everybody, feel free to call us. We can help you with referrals. We can help you expedite appointments. We have a free screening this Sunday that we'd like to see everybody at. If you need it, please, yourself and your family members. The long arms of SBH are here to welcome you. So thank you.
So first I want to thank Julie. Thank you, Julie, for putting together this night. And as I was saying, I'm going to make a speech. Someone said thank Hashem, so of course we want to thank Hashem for allowing us to be here and for doing this. And I want to thank all of you for coming this evening. This event, can you hear this microphone? Can you hear me? This event is all about men's health awareness. And obviously, you know, it's sponsored by SBH. And I want to clarify, this is not a fundraiser this evening. Okay, so we're clear. And tonight, for me, is especially an important night, as I have the honor and privilege to introduce to you two very important people. Two people that are very special to me and to my family. First, I want to introduce you to Rabbi Lazer Goldwasser, the guy with the long coat. He is the new liaison of medical referrals at SBH. And simply put, he's the best in the business. Okay? He's a genius. He knows the business of doctors and which doctor is right for which case better than anyone else I've ever seen. And truth be told, he's my secret weapon when it comes to medical referrals. He's absolutely my secret weapon. I cannot possibly express my gratitude towards him for what he's done for me and for my family. When my father wasn't feeling well and needed some very serious doctors, it was the rabbi who came to the rescue. He understood very well what my dad needed, and he mobilized immediately, and he got us the right doctors. Not only did he give us incredible recommendations for who we needed to see, he also had their cell phone numbers. He helped me to get appointments immediately. He spoke with them on weekends where we had to, and if he saw we were nervous about an appointment or something, he would even come to the appointment with us. He would tell me, I'm going to be there that day at 3 o'clock. Are you there at 3 o'clock? Oh, okay, I'm going to be there at 3 o'clock anyway. Sketch. He came to be with us on the appointments he knew that we needed him there for. And we got incredible attention and care from very special, from the most special doctors because of our affiliation with the rabbi. He's been doing it for years. This is what he does. And I'm going to say it again, he's the best in the business. And what I'm happy about is that now, I know him for years. He's one of my closest friends. But what I'm happy about is that now he is at SBH. So it's really the perfect place for him. SBH, as we all know, is the heartbeat of our community. SBH is our community. And this is, in my opinion, is perfection meets perfection. I don't know any other way to say it. So for me, I needed open heart surgery, whatever. It was the rabbi that got me the appointment with Dr. Leonard Girardi in just 48 hours. Now, Dr. Leonard Girardi is the best surgeon on the planet for what I had. And it's months to get an appointment, if you can get one at all. Not only did the rabbi get me the appointment, he came with me to that appointment, the first appointment. When I was there, Dr. Girardi told me that I was borderline for the surgery at that point, But for sure, 100%, I needed to have open heart surgery within a few years. For sure. There's no doubt about it. But in the meantime, I should not get too excited, not get too upset. Don't lift anything over 20 pounds. Don't lift my grandchildren. Don't play tennis too hard. Don't get involved in any sports too strenuously. And by the way, thanks for coming, Michael. You have a 1% chance that your aneurysm could burst at any time. And he told me, if you're a borderline case, and if, however, you're getting to there, and for sure you'll be there, if after 30 days you decide you want to do the surgery, call me up. After 30 days, you have to think about it. I won't take your call before, and then we'll do it. I went home that, it was a Thursday evening. By Saturday night, I couldn't even see straight. I called the rabbi. I said, Rabbi, done. I have to have this operation immediately. He called Dr. Girardi on his cell that night, and they scheduled me immediately for surgery that next week. Where would I be without this man? I don't know. This man saved my life. That's the truth. That's the truth. This man saved my life. That's the secret weapon right there. I'm happy that everyone here is here to meet him, if you don't know him. And I really, again, he's my secret weapon, and I hope that after tonight, he'll be your secret weapon as well. Inshallah, we should not need, but if we need, he's the secret weapon. I encourage you all, after the doctor speaks, to spend some time with the rabbi. He's an amazing man. Now, for Dr. Scherr. One of the incredible doctors that took very special care of my father is here with us right now. I've introduced a couple of you to him. His name is Dr. Douglas Scherr. He's the clinical director of Urologic Oncology at Weill, Cornell. I said that right, didn't I? That's right. That's because I'm good at this. And he is the best in his field. My family was fortunate enough to meet him through the rabbi, and I'm thankful for all that he did for my dad. His knowledge, care, and bedside manner are absolutely world-class, and it meant a lot to us. He's a calm, cool guy. You know what? In his office, he's a calm, cool guy, too. He's the nicest guy. And he knows more about his field than anyone. And I'm very excited to hear him speak. So please join me in welcoming Dr. Scherr. But before he speaks, I think the rabbi wants to say just a couple of words.
Good evening. I can't pass it, but I will say the Gemara says, "Potchim b'chvod achsanya." Whenever time you open up, you should open up the respect of the hosts. So I must say thank you. When I called Michael and says I'm planning to do a men's event, he says I don't say no. I says, but wait, call Julie. He says, Julie, no problem. Every time. So I must say thank you. And Michael is a wonderful guy, and to make him happy is not easy. Everybody knows. So, but I accomplished the mission. I must say that my new house, my new home, my new base is SPH. I'm amazed with the exposure and the services the SPH deliver for the community, in there for the community, in care. And I hope that nobody should need it, but in time of need it, we are there, and we immediately are servicing the public. I didn't buy any papers, but I'm speaking from my heart. Any services definitely will come to our department with the director of Item Wells, new director for the medical team, but we're there, and we will be there in any time of need. I must say something about Dr. Scherr. It's easy to make my job when I have people and friends like Dr. Scherr around me. Very easy. Because if I call him 2 o'clock at night on the cell, or if he's traveling, and I make a conference call between him and the patient to comfort the patient, so I became the hero, but he deserved the credit. It's unbelievable. I'm not going to speak about his expertise. This everybody knows. He's one of the world famous urology, oncology doctors. But he's humanitarian. I never saw him get upset. I tried numerous of times to get him upset. Never. And I can get easy the doctors. I get doctors upset. Never saw him upset. Always with a smile. Always there. You know what? I will see the patient in between two surgeries, and he works very hard. Being a director, he works very hard. It's unbelievable. So he deserves the credit to be a real mage. It's unbelievable. And I will give the podium to Dr. Scherr. And thank you everybody for coming. Hopefully we'll meet in Smachot.
Well, thanks everyone. I first want to thank our host for having this. Is really a wonderful event, and it's sort of giving me insight to such a great community. So it really a true privilege to be here. And I would be remiss if I didn't thank Rabbi Goldwasser as well. As he alluded to, he's not a colleague, he's a friend. We've known each other for more than 20 years now. We've traveled the world together, and every one of the patients he ever sends me really not only becomes a patient of mine, but he becomes a friend. And to me, that's what this is all about. I've gotten to meet really great communities like this, and every day I never regret accepting an offer from the rabbi to come speak to someone or come see a patient. So I wanted to thank everyone here for coming tonight. So what I thought I would do today is just give a brief education or overview of the prostate and prostate cancer. We hear about the prostate all the time, and 90% of the people that we talk to don't even know what the prostate is, where it is. And it's great to see a lot of men in the audience, but it's even better to see a lot of women in the audience too, because I think, everyone, this is not a disease that affects one person in a family. It always affects more than one person. And so it's important to have everyone here. So I'll go over an overview, and then I'd be happy to answer any questions afterwards, and feel free to stop me along the way. So just anatomically speaking, what is the prostate? And so if we look at this picture right here, this is the bladder that you see here, and this is the urethra where the urine comes through, and right between the bladder and the urethra is this walnut-sized organ called the prostate. And the urine runs right through the prostate, and that's why any problem with the prostate often manifests itself of having trouble urinating. What's the function of the prostate? By and large, the number one function of the prostate that enables you to have children. Okay, having children is the key attribute of the prostate. It contributes to a man's ejaculate, and most of the ejaculate comes from the prostate and two glands that are next to the prostate called the seminal vesicles. It's necessary for male reproduction, and the fluid within the prostate supports sperm transport that allows fertility to occur. So those are the main functions of the prostate. Now, having said that, many problems can occur with the prostate, and certainly not all of them are cancer. In fact, the vast majority of problems that affect the prostate have nothing to do with cancer. And so if any of you have trouble urinating, get up at night, urinate, can't empty their bladder, have a slow stream, that does not mean you have prostate cancer. It just means you probably have a little bit of an enlarged prostate. But the first problem, the most common problem that affects the prostate is prostatitis. And prostatitis is just a non-specific inflammatory condition of the prostate. It could be a result of infection, but it may not be. Most of the time it's not from infection, it's just a benign inflammation that occurs. BPH, or benign prostatic hyperplasia, that's just a fancy word for an enlarged prostate. Prostate cancer, which we'll be talking about a little bit. Infections, so urinary tract infections can affect the prostate. Urinary retention is the term we utilize when a man can't urinate, where everything just shuts down and you cannot urinate. And of course, blood in the urine can often be from prostatic bleeding. An enlarged prostate can cause some blood in the urine. Everything in a man stops growing most of the time when you're done with puberty. The one thing that continues to grow, however, with age is the prostate. And as men get older, and it happens in all men, the prostate gets larger. And the reason for that is the male hormone testosterone. So inside the prostate, testosterone gets converted to something called dihydrotestosterone. And dihydrotestosterone is what makes the prostate grow. And so there are many medications that prevent the conversion of testosterone to dihydrotestosterone. Many of you may have heard of the medication finasteride or Proscar or dutasteride. These are medications that lower that conversion rate and allow the prostate to shrink down. So that's just giving you some idea as to the physiology of the prostate. So what happens when a prostate grows? Well, as I showed you that picture earlier, the urine runs right through the prostate. It's like a tunnel right through the prostate. So as you can imagine, when the prostate gets enlarged, it compresses that tunnel and makes it more difficult to empty the bladder. So difficulty to empty the bladder is a symptom. Sometimes men, many men, in fact I would say the majority of men, once they get past the age of 50, wind up waking up at night to urinate. And that's very, very common. Some make many times a night. Some men have difficulty starting their stream. So they get to the toilet, they have to wait 30 seconds, 45 seconds before the urine starts. That's a sign of an enlarged prostate. Sometimes men leak urine. So if you're not emptying your bladder and you walk around with a full bladder all the time, you could develop what's called overflow incontinence, meaning the bladder's just so full the urine starts leaking out. Or if you cough or sneeze, you may leak some urine. Or straining to urinate. Some men really have to push hard to try and get that urine out. And all men will have some of these symptoms, and really it's a quality of life issue. If these symptoms begin to impair your ability to sleep or function during the day, then that's typically an indication you need to go on a medication to help with some of these things. And as I alluded to, so the urine comes right through here, so any compression on that point will obstruct the flow of urine, and that's what causes these symptoms to occur. So prostate cancer, of course, is the one we hear about the most because this is what people can die from. And if we look at the prostate cancer, it's the #1 most common diagnosed cancer in men in this country, prostate cancer. And that's why it's very important, and it affects, 1 in 5 men will be affected with prostate cancer at some point in their life. Now, what's happened lately, and we're going to talk about this a little later, is not all prostate cancers are lethal. And as a result, about 25% of all patients I see now with prostate cancer, we actually don't even treat because they're diagnosed with a non-lethal form of prostate cancer. So that's probably the biggest change that has occurred over the last decade, is we know a lot more of the natural history of this disease, so we don't have to treat every patient with prostate cancer. So in 2022, there was over 260,000 new cases of prostate cancer. So as you can imagine, everyone knows somebody who's had prostate cancer. It's just inevitable. Almost 35,000 men will die from prostate cancer. So as you can see, although it's very common, a far fewer number of men fortunately die from the disease. The highest death rates occur in African American and Caribbean American men, by far. But in this country, 1 in 6, 1 in 5 patients will get prostate cancer at some point in time. This is just a map over different countries. You can see, interestingly, in China, they have very low rates of prostate cancer, and that's probably related to diet. Some diet, some genetics. In China, and that's changing now that China's becoming more westernized. They're eating more red meat, more fast food, and we're seeing prostate cancer rates go up. But what's really interesting with this disease, if you look at Chinese men who live in mainland China, their rates of prostate cancer are quite low. When they move to an intermediate environment, like Hawaii, for example, their rates go up a little bit. And then all of a sudden they move to the west coast of the United States, their rates become equal to non-Asian patients in the U.S. So there's clearly a dietary trend and lifestyle trend in prostate cancer. This is prostate cancer in African American men. Obviously doesn't affect this audience. Suffice it to say it's just more common in that group of men. I'm not going to spend a lot of time on this. What I do want to spend is diet. So we hear a lot about diet in prostate cancer. And, people ask me every day, what can I do to prevent prostate cancer? And at the end of the day, we don't entirely know. But what we do know is a heart-healthy diet is also healthy for your prostate. So saturated fat intake is clearly been implicated in prostate cancer. High red meat intake. So if you're someone who eats red meat 7 nights a week, you probably need to change that because that's going to result not only in prostate cancer but colorectal cancers. There's a lot of data to show that soy-based products have a protective effect against prostate cancer. So if you like edamame, you may have heard of that, or any of the soy-based product, tofu, these are healthy options. There's some evidence that vitamin E may have an effect or impact. We used to think selenium and lycopene, these are high in tomatoes and red sauces, may have some protective effect, but overall, a heart-healthy diet is also healthy for your prostate. So what do we do? How do we screen for prostate cancer, and who should be screened? At the end of the day, if you have a family history of prostate cancer, meaning you have a first-degree relative who's had it or died from prostate cancer, you need to start screening at age 40. Otherwise, if you have no family history, age 50 is when we recommend screening. And screening includes a blood test, which is a PSA exam, a rectal exam, and if either of those two are abnormal, then a prostate biopsy. And we'll talk in a little bit later why we're a little bit less reliant on the rectal exam these days and more reliant on the blood test and an MRI, which I'll talk to you about in a moment. But everyone should get screened at some point in their life, certainly at age 50. If you have a family history, that should start at age 40. So why is the rectal exam important? Well, just above the rectum is the prostate. So if you feel, and years ago, when this disease was diagnosed typically at more advanced stages, you could feel nodules or firmness or induration in the prostate through the rectum. Nowadays, with screening, we diagnose disease at a much earlier state, so it's far less common to feel an abnormal rectal exam. Occasionally we do, but it's certainly less common. The blood test is critical, which is called the PSA, which stands for prostate-specific antigen. And it's a simple blood test you can get in your internist's office or urologist's office, wherever they may be, and they can talk to you about the abnormal, whether it's normal or abnormal. So the question is, does screening help? And here's a really interesting fact. So about a decade ago, the U.S. Preventative Task Force, which is the arm of the federal government that determines health policy, came about and said PSA screening is worthless. It doesn't do anything. And they came against the recommendation of PSA screening. And that was partly based on a very large study called the PLCO trial, which randomized patients to screening or no screening. And this is a perfect example why you can't always believe what you read. So at our program, and this was a very, very well, it was published in the New England Journal of Medicine, a big, big trial. And one of my residents, his name's Yoni Shoag, he was a resident with us, said, wait a minute, this doesn't make sense. And what he did, he went and took the raw data from this trial and found out that they thought they were comparing screening to unscreening. And what he found out, in the unscreened arm, 90% of the men actually were screened. So the whole trial was worthless. And so we published this study, and after that study, the U.S. government came back and said, okay, we now recommend screening. But the problem became, right now we're seeing the impact of that. So right now we're seeing far more advanced prostate cancer because a lot of men did not get screened for almost a decade. And as a result, we're seeing men with more advanced disease, more aggressive disease, and for the first time in a long time, we're seeing the death rates of prostate cancer go up. And so that's why it's really critical to screen for patients, because we know in the early point of screening, we were able to drop death rates of prostate cancer by 27% just by screening. So it's critically important to get screened for prostate cancer. It's a simple, simple test. So what happens if your PSA test is abnormal? Well, nowadays, the next step is to get an MRI. No one should ever have a biopsy without first getting an MRI. So if your doctor tells you you need a prostate biopsy, without an MRI, it's not the best way to go about it. The first thing you need to do is get a special prostate MRI. And the reason for that is, nowadays, we don't just do random targeting of the prostate. We actually do what's called an MRI fusion biopsy. So we have a computer software that takes the MRI images and fuses them with the biopsy, so we specifically target the areas that are abnormal in your prostate. And we found that we can not only localize cancer much more efficiently, but we're only finding the cancers that are significant. We're not finding the insignificant ones that we don't need to know about. And so the key is, if your PSA is abnormal, you get an MRI, and then you get an MRI fusion biopsy. And nowadays, we used to go through the rectum all the time to do the biopsy, but now we do what's called a transperineal biopsy. The perineum is the space between the scrotum and anus. And so what we do, we give you a little anesthesia, a little sedation so you don't feel anything, and we biopsy through the skin of that location, and the infection rates are much lower than doing a transrectal biopsy, and we're able to diagnose prostate cancer that way. So that's sort of the state of the art now in doing what's called a transperineal MRI fusion biopsy. Okay? So what if you're diagnosed with prostate cancer? What's next? Well, there's lots of different options. As I said to you from an earlier point, active surveillance is the fastest growing form of treatment for prostate cancer, and in actuality, it's no treatment. So in active surveillance, we still follow you very closely. So if you're diagnosed with a low-risk prostate cancer, and so low risk means, you may have heard what's called the Gleason score. That's how we grade prostate cancer. So a low risk is a Gleason 6 prostate cancer. And so if you're diagnosed with a Gleason 6 prostate cancer, the next thing we do is get what's called a genomic risk score. And it's a test that you don't have to do anything for. We order it off the biopsy, and we actually analyze the mutations of the cancer cells on the biopsy to see if it's really low risk. And so if your genomic risk score is low risk and you have a Gleason 6 prostate cancer, we would put you on active surveillance, meaning we follow you every 6 months with a PSA. Once a year we get an MRI, and a year after your initial biopsy we do a confirmatory biopsy to make sure nothing's changed. And that's the crux of active surveillance. And the key with active surveillance is when and if you need treatment for your prostate cancer, it should be as equally curable then as it is the day you're diagnosed. And so that's a really big segment. As I said, about 25% of men we put on active surveillance. Hormonal therapy, and I think I speak about these in a little more detail, each one. So active surveillance we spoke about a little bit. Hormonal therapy, you know, testosterone, the male hormone, is what makes prostate cancer grow. And in fact, the only urologist ever to win the Nobel Prize was a guy named Charles Huggins back in the 1940s, and he won the Nobel Prize by discovering the relationship of testosterone and prostate cancer. And so now we have medications. So years ago they used to cut off a man's testicles to lower your testosterone. Nowadays we don't do that.
It's a good thing.
Yeah, we give you medications that can do that. But by and large, hormonal therapy is predominantly utilized for men with metastatic prostate cancer. We don't use it for men with localized prostate cancer unless it's given as an adjunct to radiation therapy. So sometimes men who have large prostates, we give you these medications first to shrink the prostate and then give you radiation therapy afterwards. But hormone therapy is a big component of treatment for prostate cancer. Radiation therapy, the gold standard for radiation, you may have heard the CyberKnife ads on the radio all the time. And CyberKnife is a form of what we call SBRT. It's a form of focused radiation therapy. So years ago, it used to take 45 days to get radiation. Nowadays, we're able to give it over 5 days. So you come in Monday through Friday for about 20 minutes a day, you get zapped with radiation, and that treats the prostate cancer. And that's you know, probably radiation and surgery are the most common forms of treatment of prostate cancer. Surgical therapy, of course, again, you see the prostate right here, and now here there's no prostate. Surgical therapy, we remove the prostate, and I would say 98% of all prostatectomies now are done robotically. And the key aspect of surgery, you want to achieve the trifecta after treatment, meaning you want your PSA to be 0, you want to have no urinary leakage, no incontinence, and normal erections, okay? And I think that's readily achievable in the vast majority of men if the surgery is done correctly. And there's key nerves that run just next to the prostate called the cavernosal nerves, and this is what gives a man the ability to get an erection. And so one of the benefits of robotic surgery is everything's magnified 12-fold. And so my ability to see these nerves and peel them off the prostate is much greater when I do this robotically than when I could do this open surgically. And I think as a result, we're able to do much better nerve sparing and really maintain quality of life. Quality of life is the key aspect to treatment because fortunately we can cure most of these patients, but you don't want to cure someone and leave them in diapers and not able to get erections. And so quality of life is a critical aspect that you need to discuss with your doctor when you're getting treatment for prostate cancer. So some of the big advances recently, I spoke a little bit about MRI. So again, it's critical if you have an abnormal PSA to get an MRI of your prostate. Genomic risk scores, so there's several tests available now. There's a test called a Decipher test or an Oncotype test. These are tests, again, where we look at the genetics, the mutations that are within the cancer cells in your prostate, and we have such a broad understanding of these now to determine which ones are associated with good risk and which ones are associated with high risk. PSMA PET scans, that's a test that was FDA approved just this past year, And this is a special kind of PET scan. PSMA stands for prostate-specific membrane antigen, and it's a protein that's preferentially expressed on the surface of prostate cancer cells. And we have small molecules now that target those, and so we're able to visualize them on a PET scan. And so this is probably the biggest advance of prostate cancer lately, and we're getting these in almost all patients nowadays because it looks at your whole body. It just doesn't look at the prostate. It looks at your entire body, and it tells us, are there any cancer cells anywhere else? The other thing that it looks at and feeds into another fast-growing segment of prostate cancer treatment is called focal therapy. So nowadays, because we can image prostate cancer a lot better on the MRI, and we can image it on these PSMA PET scans, we're actually able to just burn away, in certain patients, just parts of the cancer that's in the prostate and leave the rest of the prostate intact. And that's called focal therapy. And so that's also a very new form of treatment. We're gaining a lot more knowledge on it right now. But there are certain patients who have isolated disease that are good candidates for focal therapy. So I guess in conclusion, I just want to say, obviously, critically important, everyone needs to get a PSA test. It's really, really important. It really allows us to decrease the death rates of prostate cancer. If you have friends who are African American, they need to be screened at age 40 because they're higher risk. And treatment really has dramatically improved over the last decade. We're able to really maintain quality of life in the vast majority of patients. We're able to cure a lot more patients than we once could. And so I think a diagnosis clearly doesn't mean a death sentence, and it clearly doesn't mean you have to walk around in diapers or become impotent. Those are sort of decades-old folklore, but nowadays we're able to do a lot better than we were certainly a decade ago. So I'll leave it at there, and I'd be happy to answer any questions or any comments that people have. Yes?
Does the MRI spot the cancer cells? Or it's
So-
just a biopsy that does that?
Well, the biopsy is what confirms the cancer cells are present. What an MRI does, it looks at different areas of the prostate and gives you a score. It's called a PIRADS score. And it's a scale of 1 to 5. A PIRADS 1 means there's definitely no cancer present in that spot. A PIRADS 5 means that there's very likely to be an aggressive cancer present in that
Or
spot.
does it spot the cells?
It doesn't spot cells. Ultimately, that has to be done with the biopsy.
Now, the biopsy is usually 12 cores.
So
Correct?
it depends.
So you can miss it.
Well, no, the beauty of the MRI fusion biopsies, though, is we're able to target those areas that are abnormal in the MRI, and so there's a much lower likelihood we're going to miss cancer. That's the beauty of the MRI. Yes.
Before you said that you did surveillance, and it was one of the first steps that you took.
Right.
Is that because, I mean, doing the surgery and doing all these things are very, being proactive on treatment is not a good thing?
No, not necessarily. I just think not everyone needs treatment.
Right.
So there are certain prostate cancers that, although there's microscopic evidence of cancer cells, they're not the kind of cancer cells that are going to spread or kill you. And so we only want to treat patients that really need it. And so we now have a better understanding genomically and genetically which cancer cells have the ability to spread and which ones don't.
Have there been any studies where you know that there's a certain cancer, but you segmented some people that didn't want treatment at all, and so
Yes,
what happened?
we have long-term data now on active surveillance, and the vast majority of people with low-risk disease never recur. They
But
never
what
need
if you
treatment.
do have it? Has it ever been shown to fix the problem through diet or anything of nature?
Will the cancer go away completely?
Yes.
It's a good question. We have no data really to show that we can eradicate cancer cells short of treating it. But we have data to show that you don't always have to eradicate these cells. So just because you have cancer doesn't mean you have to treat it.
Is there any likelihood of false PSA reads?
100%, yes. PSA, believe it or not, it's the best test we have, but it's not specific for cancer. So all those things I showed you earlier, prostatitis, infection, urinary retention, bleeding, all of those can elevate your PSA too. Riding a bike the day before you get a blood test can elevate your PSA.
So what's your suggestion if you get a
Well, you
high
have
PSA read?
the first thing we always do is repeat it. We always say first
Repetition.
repeat it, make sure it's real before we act on all
Is
this.
there an antibiotic treatment?
Sometimes in patients that may have symptoms of prostatitis or infection, we may treat them first and then repeat the PSA after that. Yes, so you always have to take PSA in the context by which it's being done. So if someone comes in and say, I just rode a 50-mile bike race yesterday and I'm getting my PSA test, you probably should wait a few days. You should avoid sexual relations 48 hours before getting a PSA test.
So I understood that it was unusually likely. So that's relieving.
No, it's
Well, if
highly
you don't read-
likely that you could have a false positive
high
reading.
positive PSA reading.
It's not a false high. The level is that high, but
But
false
it's not.
positive, that doesn't signify you mean you have cancer.
Could be a false reading when it's low.
Not typically. A low PSA is typically a low PSA. Yeah.
Is there a PSA number where you won't suggest watchful waiting?
It's less reliant on the PSA and more on the biopsy. The biopsy dictates whether we could do active surveillance, not necessarily the PSA.
Not necessarily.
Correct. Yes.
Why is it, I think most men have the problem of the enlarged prostate. Most people. I find that for myself, at night, I go a lot. During the day, I'm not as much.
Yeah.
Why is it that at
So-
night that I go
Yeah, it's a good
so much,
question.
and during the day, I could go 6 hours without going?
So the main reason for that is everyone makes more urine at night. Because what happens is you're walking around all day, standing up, all the fluid accumulates in your legs. And so all of a sudden you go to bed, your legs now become elevated and all that fluid gets back to your kidneys and makes more urine. So what I sometimes tell people is an hour before getting into bed, elevate your legs while you're watching TV or something, so you'll get rid of all that fluid before you go to bed. Number two, you could urinate twice before you go to bed. So some people don't empty their bladder, so urinate once and then 10 minutes later try and go again. And the final thing, which a lot of people don't realize, a lot of people just drink a lot after dinner. So if you're going to drink a lot at night, you're going to pee a lot at night. So I think if you do some of those behavioral things, you can really get rid of a lot of that.
I didn't understand the part about elevating legs. How does that help you?
The reason that helps is because your legs are dependent all day long. All the fluid accumulates in your legs. And then all of a sudden when you get into bed, your legs go up, so the fluid from the legs starts getting washed back to the kidneys, and you make more urine.
There's a drug called tamsulosin that reduces, if I'm not mistaken, the frequency of urinating in the night, right?
Right, so tamsulosin, also called Flomax, is a medication that relaxes the smooth muscle within the prostate. So if you have a tunnel through the prostate that looks like that, tamsulosin makes that tunnel bigger, and it makes it easier for the urine to go through.
Is that dangerous long term?
No, there's no long-term consequences. The biggest side effect of tamsulosin
Drowsiness.
is it can cause dizziness, and sometimes it causes what's called retrograde ejaculation, meaning you don't ejaculate because it goes backwards into the bladder. It's not dangerous, but people get concerned when they see that, but it's not a sign of anything bad.
Rabbi wants
Yeah.
to speak.
Is there two questions? First, is there any physical symptoms like skin color change that you could spot when somebody?
Not really. The biggest symptoms of any prostate disease have to do with urinary issues.
And also, when the prostate cancer metastasizes, where does it usually go?
It can go anywhere. One of the most common spots it goes to is the bone. The bone is a very common spot of prostate cancer, but it can go to lymph nodes. It literally can go anywhere. And, we've seen patients who have PSAs 5,000, who have just diffusely metastatic prostate cancer. And prostate cancer can go, but, fortunately now we have a lot of really new and novel drugs to target. So metastatic prostate cancer has become more of a chronic disease, and far fewer people are dying from it now because we have much better drugs.
And the
that's it.
same drugs will treat the metastatic prostate cancer as the prostate cancer itself?
No, well, you have different drugs when it's spread outside the prostate. We use different drugs. They're all predicated on manipulating the testosterone and hormones components of it, but they're not used if your disease is localized. Yes.
I understood you said younger age, testosterone is strong. Over the age of 50, it gets weaker, hence the swelled bladder, or the swelled prostate.
Right.
Yet, when someone has a high PSA, they have too much testosterone. So,
Right, so it's a good question. So testosterone doesn't necessarily go down with age in everybody. There's a subset of men where it does, but keep in mind, it's not the testosterone that's the culprit. It's the dihydrotestosterone. It's the enzyme within the prostate that converts testosterone to dihydrotestosterone. So, you know, what I always tell people, there used to be a dictum years ago saying, oh, don't take testosterone replacement because it can cause prostate cancer. But that's not entirely true, and I think I'm not recommending everyone go out and take these super physiologic doses of testosterone, but if you're someone who suffers from low testosterone, it makes sense to replace it. But you really should be seen by someone who has an expertise in that area. You know, I wouldn't just randomly go on these herbal supplements or any of these things, because they can have dangerous side effects as well.
So you mentioned before, when you take a blood test and they check for PSA and you get your results, what's the number that's
So another good
that's
question.
normal?
So, you know, there's really no, we used to say 4 is a cutoff. People used to think as a PSA above 4 is abnormal, less than 4 it's
I
normal.
mean, like 1 to 10 and 4 is
Right, exactly. But we don't really use a cutoff anymore. So it really depends on your age, your family history. One of the most important things we look at now, instead of the absolute number of PSA, is the PSA velocity, meaning the rate of change of PSA. So if you get a PSA, we tolerate a change of 0.75 a year. So everyone's PSA will go up with age. But if your PSA rises by more than 0.75 in 1 year, even if your PSA is 2, that's probably a warning sign that you should get an MRI.
So also you mentioned, well, usually when I get a blood test and they tell me a PSA number, there's usually another column how much it was before.
Correct.
So they look at that.
It's critical to get, yes, a few values. That's the most important thing.
But you
can
also
look at.
mentioned that you shouldn't rely on that first test, you should take another test?
Correct.
How soon after?
You know, it depends. I think if you all of a sudden, if your PSA has been like 2.5 for years, and all of a sudden you come in, your PSA is 6, I would say just let's repeat it in 2 weeks and make
What
sure.
if it's the same all the time, you know?
Well, then if it continues to be 6, then you should get an MRI and probably have a biopsy.
If it continues to be 6. but
Well,
if
I'm
it's-
using that as an example, but
Yeah, yeah,
yes. If it continues to be well above your typical baseline, then
But
you
if
should.
if it doesn't, then you just
Right, if it goes back down to 2 and that's where it's been for a long time, then don't worry about it.
don't worry about
Yeah.
it. And what's the relationship between an enlarged prostate and cancer?
No relationship.
No relationship.
There are people who have, you know, a normal sized prostate's about 30 grams, 30 cc's. I've seen men with 300 cc prostates, no cancer, and I've seen men with 10-gram prostates that have cancer. So, as they say, size doesn't matter.
Oh.
And similarly, I've seen men with very large prostates that have no urinary symptoms. And I've seen men with 20-gram prostates that are getting up 10 times a night. So size really doesn't tell the whole story when it comes to both cancer and
So
urinary
no
symptoms.
relationship between the size and cancer itself.
Correct.
So what cancers comes to the prostate?
We don't really know why it occurs, but there's clearly dietary elements, genetic elements, but it has nothing to do with size. Yes.
When they do the rectal exam and they see that it's smooth, doesn't mean to describe the prostate as a donut. So that the other side could have.
Correct. You're only feeling